Hi,
Hi, Martha. How are you?
I'm good. Can you hear me and see me? Everything
I
well?
can hear you. I'm not looking at the screen right now. Yes, I can see you too. Perfect.
Awesome.
How are you today?
Good.
Good.
Uh, Ready?
Good. I'm glad.
Let's
We
see.
got good feedback from the last one, so I'm
Good.
sure.
Today, I know one of the things that you asked was like to, well, share the slides and stuff, but today's gonna be more um, talking about the
Yeah.
yeah. So
It'll be more interactive today, you think?
correct. Yes.
Okay. Great. Good. I think people will be excited about that.
And I hope to sing. I'm gonna close as much um, screens here so I don't get confused.
Since we don't have anybody else on, I'm going to ask you about this, Martha. We are still looking for 3 more participants for the mini documentaries that Katinka is going to be doing. They're going to be professionally shot. We're offering $25 an hour stipend for people to tell their story about trying to access mental health services when they have Medicaid or have had Medicaid in their lives or have kids with Medicaid. And we're specifically looking for some people with more diverse backgrounds at this point.
Okay.
And we're also looking for some men. Do you have any ideas? If I send you the information, do you know if clients at Access would be interested? I did share it with Beth too.
Yeah, I think even Beth, it's better than me right
Okay.
now, as she's more in clinic than myself. I'm just so
Okay.
limited that
Okay.
I think what I was thinking you already did, which is share it
Yep.
with her.
Okay. I've got a call into the Boys and Girls Club who I thought might be good, especially for a parent in Dane County. Um,
The other one that I'm thinking is Journey.
oh yeah, Journey's a good one. Good point. Yeah, I bet they'd be really good. Yeah, I know some people at Journey. Lots of
Yep.
people there, so I'll hit them up and see what I can do.
Sure.
Good idea. Good
Yeah.
idea. Okay. We got a lot of women that are participating, but we need some
Yeah.
men. Yeah,
Yes.
which is
That's hard. That's a hard
doesn't
one.
surprise me one bit, right?
Yeah,
Yeah,
exactly.
yeah.
Yeah.
Oh, is Naphtali joining today too, or just you?
No, he's joining.
Oh, he
Yeah.
is. Okay. All right.
He should be here. What I don't know if is he coming from another meeting or
Gotcha.
uh, that I don't know. So most of the times we're together, and
Yeah.
I know his agenda, but um, I don't see anything in the hour like with these hours. So I think
Yeah.
he's fine.
Oh, okay.
I think he's free, but we'll see.
Yeah. Nice.
Are you already sick of the cold weather or hanging in there?
I'm so ready for spring.
I
So
know, like
ready.
late February and March are the
Yeah.
hardest for
They're
me. I'm
so
like, oh,
hard. Yep. I spend my entire time looking at the weather forecast, like n- talking myself into being able to make it until the next nice day, you know? So,
yeah,
yeah.
yeah.
I I set this up so people could automatically get in, but it looks like people are having to come into the lobby and I'm having to let
I
them in.
yeah, I needed to like wait, and it says you're
That's weird because I specifically went in and changed the
you don't see Neftali there.
no.
Let
He's
me text him.
not. Okay. Nope, there's nobody out there right now. I'm going to go back into the settings again and see if Hi, Karen. I set it
Hello,
up.
how
So
are you all?
good. How are you?
Oh,
Good.
Good. I set it up so people didn't have to could bypass the lobby, but
I don't know how all the settings work in here, so
yeah.
I'm pretty jealous that you even knew how it started.
Oh, you're not talking to the techies.
you know, you know how you changed from Zoom to Teams
Yeah.
and you don't see no one waiting? No one? I'm
Karen
wondering,
was just waiting. Karen
I'm
was
wondering,
waiting.
no, and I don't mean Neftali, like in general, people.
Yeah. Yeah.
No one. I'm wondering if people didn't read the email and they're in, I mean, I don't know if there's a way to have someone in. Oh, so there's no
So
way.
they
Oh,
would have to take it off their calendars. Yeah, I removed it from people's calendars.
okay. Okay.
Yeah.
I was just
So
like,
hopefully, and a whole bunch of people accepted this Teams one. So hopefully, yeah.
yeah.
Well, they'll be
There
here.
they
It's
are.
kind of early, so yeah, they'll
Yeah,
come.
they're coming. People are coming now. There's Katinka. Hi, Katinka.
Hello, how's everyone doing?
Good. How are you?
Great, I'm doing pretty good. Hi, Martha.
Hello.
I set this up so people didn't have to come in through the lobby, and I just confirmed that I did that, but people are coming in having to be admitted, and I'm not sure why, but I'll work on it again after the meeting.
Yeah, it's interesting. So it looks like I'm getting the request for admission. Is anyone else?
I am.
You are, okay.
I'm letting people in. So it must just be coming to everybody, but I'll fix it after this meeting, hopefully. We're new to Teams, so
It's a lot. There's a lot of whistles with Teams.
I do like it quite a bit, though. It's a nice app. I like it better than WebEx, which is good.
I agree.
Welcome, everybody. We are just waiting for everybody to join us today. Hi, Naftali.
Hey, everybody.
We're still waiting on most of the folks. People are just coming in.
Martha, I probably don't even need to ask, but you have all the stuff pulled up, right?
It's full up, yes. I do. Just open your Basecamp so you can read the other ones, but I do have the rest of the information here open, and I share it also with everyone, so everyone can actually open from their computers, either the PDF or the virtual, whatever they want.
Perfect. Everybody doing okay today?
Yes.
I won't ask how the weather is. Don't worry.
Yes.
It's actually not terrible today. It's like 38. So that's pretty, it's like spring.
Yeah. As long as you have sunshine, that's
Wow. Hi, John. Glad you made it. Sorry about the confusion before. We're on all sorts of new platforms, and life has not been so easy for this not so techie person.
Well, I'm right behind you on that. So
Glad you're with us today. We're just going to wait for another minute or so, everybody. I did set this up so that you guys didn't have to wait in the lobby, but apparently that's not working. So I'll fix it before our next meeting. We're brand new to Teams this week. This is our first big meeting in Teams. So Why don't we give it about 1 more minute before we get going? Because we only got about five people on and 12 said they were coming. So I'm going to wait for just another minute or two. Here they come. Can I ask who the person is that called in, just so that when I'm doing the checking everybody up?
This is Marcia from Reedsburg, and we actually have a group of us in one room. So I've got Erin Fink, Kathy Anderson, and Dr. Mary Beth Shear, and we're all in one room.
Oh, perfect. Then we've actually got quite a few more people on. So I'm gonna turn it over to Martha and Neftali, and we can get started. And I'm gonna turn off my video so I can take notes without everyone watching. So we'll get going. Thanks, everybody. Welcome.
Yeah, hello everyone. I am again Neftali Serrano. I am in a I promised I wouldn't mention the weather, so I'm not going to say anything about where I am with respect to, but I am a former Wisconsinite, so I know what February's can be like. I'm so glad to hear that your day today is not as bad as I remember. So I'm here with Marta Salcedo, our project manager for technical assistance, and we're really excited about this conversation today. This is a really fun conversation to have and a really practical conversation around how you can evaluate yourself and your team's progress with regard to integrated care. However, before we jump in, we really want to be responsive to your needs and the things that are most important to you or top of the mind. So if there are some specific burning questions you have that maybe doesn't necessarily relate to what we're going to be talking about today, please feel free to post in the chat, and Marta and I will take a look at those and try to integrate that into what we talk about today. And if not, we'll just take some time out just to answer questions or to address those issues as we're able to today. The good thing is that what we're going to talk about here with the practice integration profile tool is something that's going to cut across a lot of typical questions. So probably there's ways to integrate so it doesn't feel so jarring of a conversation. But Marta got all of your stuff, put it all together in terms of a response set. So I'm going to turn over to Marta to talk to you a little bit about what you all said in your practice integration profiles here. So Marta,
well, actually, so we send the link to everyone, and everybody, filled it out, but they didn't return it back. So they got their responses, and they know what they got, but I didn't receive. He's confusing other projects here.
Yeah, great. There was another project where she's gotten the responses. Right, we didn't get these responses from you. So we're going to actually ask you to give us your feedback on those responses. So just to give you some insight, what Marta and I typically do if we're working with a client is all the team members will give us their PIPs, and then we aggregate those and give feedback to the team on those. And then that helps the team understand how concordant their responses are between team members. And Marta, what do we usually find out with
and actually, I actually have it here because I wanted to share just the vision of one of the graphics for them to know that it can look so very different. With that being said, I want to see how I can share this if I can. I just want you guys to kind of visualize, if it's possible, but I don't know where the share button is.
You should be able to. Hold on just a second. You don't have a share button there?
No, but anyway, what we, I don't want to lose time with technology.
Okay.
But what we want to say is that usually this assessment will give it, to a site, and not just one person will fill it out, but we try to incorporate a lot of people on the site, right? All about from medical providers, administrative people, medical assistant, BHCs, look, everyone. And what we find out is that actually the responses can look so, so different. Like someone can think or perceive that the integration of the workflow, for example, because you probably realize that there's several sections, or we can talk that there's different sections on the assessment, and someone can perceive that there are like a 50, percent, but then we have someone that is on 20 or even bigger of a gap. So that gives us a lot of information as to how the same people experiencing the same site can perceive things very differently. And those are things in which we need to work on, because definitely the integration, it's different from the view of one person or the other.
Martha, if you do want to share, there should be an arrow next to the red leave button in the corner, and that's where you can share.
Yeah.
Just
Or next to
confirm.
the microphone. I think it's the.
Yeah, in between the leave button and the microphone.
So while you're looking at that,
I see.
I'll just say a specific example would be, we often find, for example, that a site says, oh yeah, we're screening for depression. Yeah, 100%. So that's an administrative level person talking, right? And then the medical assistant is like, actually, we started doing that, but then the person who makes the copies of the PHQ-9 left. And now we kind of do it some of the time when the provider asks, right? So that sort of communication on the team around what's actually happening with integration work is part of what we find pretty frequently. And that's why this assessment is helpful for your teams. So just to give the big picture of this, the way you would use this tool is you would give it to various of your team members up and down your organization, a representative, say a medical assistant, a nurse, your CEO, CFO, a primary care provider, a behavioral health provider. And the nice thing about it, pretty easy to score, right? And then you put your scores together, and you're able to see across your team the areas where you're probably assuming you're doing certain things, but you're not. Areas where you're doing really well, and you can build on those strengths. And maybe target areas, and that's what we typically do with folks. We try to help them identify target areas where, if you want to improve your efforts towards integrated care, you want to work on this area. Like you want to work on your the accessibility of your behavioral health personnel, for example, or you want to work on your screening processes, or you want to work on your care planning, or your utilization of the EHR, et cetera, right? So it helps you really get tangible steps you can take in that process. So what we're going to do today is we're going to actually go through some of the elements here so you understand what those elements are. That'll also open up a conversation around how you're defining integrated care at your sites, naturally speaking, right? I mean, this is exactly what we're trying to say. How do you define this?
Go ahead, Jen.
Yes.
I just want to say, as you guys are talking through these different elements, if there's any of the health systems on who want data on any of these elements that they might report to WCHQ, we could pull custom reports for them so they can see, are they scoring high, or are they, so like for the PHQ-9, for instance, we have all of the data by health system for PHQ-9 utilization. But there's many other elements that we could potentially pull data for them on. So if anybody's interested in that, you can shoot me an email, or you can bring it up today, and I'll make sure you get data to help take a look at a particular element.
That's right.
And we're not going to go item by item because will take us hours. But what Neftali and I did was that we picked those items in which they can easily be misunderstood, or that are some of the things that we do see sites struggle the most. So those are the ones that we're going to start highlighting. For example, I have here one regarding the workflow, in which the question says if you have behavioral health and medical clinicians together, they're actually collaborating. And a lot of people interpret this as, yeah, we're working together, that's fine. And that doesn't just involve like seeing patients, seeing the same patient, reporting to the provider, like closing the loop, but it also means that you're constantly working in regards to the same issues for patients. For example, those medical providers and behavioral health get together to identify, we're really struggling here in clinic with substance abuse. How can we work together, right? So not just is the day by day and seeing that patient, but in generally assessing the needs of the site together. Because a lot of the time those meetings happen, but it's just medical providers and behavioral health is not included or invited. So then you're not working collaboratively, right? Because if there's an issue that you're seeing a particular population of patients, it's not just the medical providers who need to be there, but also invite to the table behavioral health. So this is a question that it's important not just to think about the day-by-day patient, but in general, to work collaboratively in everything in general related to patient service.
Yeah, that's a great point, Martha, because so then a take home would be, let's say you scored very low on this item, right? Or if you had some team members that scored very low, maybe your behavioral health people are like, hey, wait a second, you guys we're not in any of your meetings, then it gives you a really tangible to do, right? It says, I wonder where behavioral health needs to be in our organizational meeting structure, right? Are they at our quality meetings? Are they at our practice improvement meetings? Are they at any C-suite level meetings? Are they in that new building design meeting, right? So it really begins to pinpoint, okay, we're actually treating behavioral health as a side project, not as actually something that's core to our service lines here. And it gives you a very tangible to do. So, it seems like a simple item, but it has far-reaching effects as far as how you can think about, maybe we don't treat behavioral health as a really core part of our business. We're really just thinking of it as a department or some sort of side projects that we're doing. And that's something that we unfortunately see quite a bit of. Yeah. So that item, by the way, WI1. It's the first item list. Yeah.
It's related to workflow. Another one that we see as a workflow is that not because behavioral health and medical providers are on the same building, they are actually integrated. We see a lot of the times a misunderstood, but behavioral health is actually in an office apart, right? Not in the same pod or not even on the same area of the floor. And this is super important because a lot of the interactions of integrated happen behind the scenes, which means not when you're seeing the patient, but when you see a provider talking to the medical assistant about a particular patient, and you can just turn and say, hey, I think this is a patient that I can see, or tell me more, I have it also, I saw that patient yesterday. So that communication on those pods or huddles, when you are physically in the same place as medical providers, is super, super important. And it's very often seen that behavioral health is like isolated in the end of the hall on an office or exam room, right? So again, talking about the integration, if that's happening at your site, take a look at where are you sitting down? Who are the people next to you? What conversations are you listening through your workday? Or you're maybe not listening to anything because you're isolated in a room, right?
And that, just for you, those of you following along, that would be on page 2 of the PDF, WI4, the workspace and integration 4, essentially, right? And so, as Martha said, architecture often is a delimiting factor sometimes. If you don't have a pod style setup in your clinics, that can inhibit. So an example is at some of the UW clinics, primary care clinics in the family medicine department that I worked with, they designed their clinics after an older style of work where each physician has their own office and they work out of their own individual office. That actually has significant implications for team-based care. It actually made it much harder to work across those physicians. So when we were trying to integrate some behavioral health into that particular building, the level of integration was kind of capped because it was really hard to coordinate across all the primary care provider and medical assistant dyads in that building. So whenever we get folks talk to us, hey, we're building a new building, Can you help us think about what to do? Do we need a separate office for behavioral health? I always tell people, no, 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 no. Save your space. You don't need a separate office for behavioral health. What you need is exam rooms and exam room space that you can share with medical providers and behavioral health providers, so you don't have to waste space. But what you do need is more of a pod setup that facilitates team-based care. And that's not just important for behavioral health. That's important for your triage nurses, for your consulting psychiatrists, for your consulting pharmacists, your dietitians, et cetera. You want as much of a pod setup as possible to facilitate that day-to-day team-based care. Now, just one little other point here across models. I know some of you are interested in both PCBH and COCM, collaborative care model work. I think this applies to both models. So too often with especially COCM work, people segment that work so much that the consulting psychiatrist has very little face time with the physicians. The care manager often has very little face time with the physicians as well, and it becomes a very segmented part. It's a protocol that's working in the background in the clinic, but it's not really well understood by the providers. They have trouble recruiting patients. There's less of an incentive to screen with the PHQ-9 because it just feels less helpful. And so even having some of those folks like care managers who, may not necessarily be integrated into the flow every day, but having some face time with those folks in the pod areas makes a big difference.
Naftali, I'm curious to hear a little bit about, what are clinics doing right now, the people that are here with us today. I don't know if someone wants to let us know regarding these two items that we talk about, the integration with being in meetings and be part of the clinic and be involved in as the same as providers, and the physical space. What are they seeing in their sites? Is that something that you guys have? You don't? Do you see a challenge making changes?
Yeah, and if you can put any comments on the chat, that'd be great. And of course, if you want to raise your hand and let us know if you want to talk out loud, we're happy to put that. But yeah, tell us what's going on at your clinics.
One of the things also, so we're going to continue talking, but please, let us know, because what we want to, help you guys is identify those challenges or things that you want to change and how to do it. So please feel free to interrupt us or, write on the chat.
Yeah, so let's
And
move
can I just ask?
Yeah.
Can I ask a quick question, you guys? So I think that you had said, and a few people have joined since we started talking about it, that the goal of today is to talk about the tool and to ask people to take that tool back to their healthcare settings and ask different providers within the healthcare settings to fill it out so they can identify some of their areas where they need work. Am I correct? Can you just go over that? Am I correct in what I just said about that's the goal of today?
Yes.
Yeah, you said it perfectly. Yeah, we want to give you something very practical to create to-dos, things that you can practically work on to say, we need to work in this area to improve our level of integration. And these items directly relate to the, we talked, remember last time, the HRSA 6 levels, right? These match up really well. When we produce a report, for example, for our clients, we match it up with the 6 levels that HRSA says are the range of integration. And we say, based on your response here, you're at a level 4. And these are the things you would need to do to get to a level 5, right? That really gives you a very tangible way to plan what you need to do. The other piece of that we talked about for those folks who weren't here at the beginning is that it also helps you understand the discrepancies between your team members, because oftentimes what the people on the clinic floor perceive is actually happening in your organization with regard to integration is very different from what folks at the administrative level are thinking is what's happening.
One item that it's very and this is more to the clinical service that we see very often is that a lot of the sites will think that they are providing behavioral health services if they see mental health issues, but they don't really are thinking about other type of issues like hypertension, diabetes, and other health concerns, that behavioral health can be included. Or even providers, they don't know these are areas where they can include their BHC colleagues, right? So it's in here in the evaluation or screener, it asks you very specific about if you're seeing patients regarding mental health issues, and then it asks you if you're seeing patients regarding health issues, and then if you're seeing also patients with serious mental health illness. And that is, I think, 1, 2, and 5 items. It's number 1, number 2, and number 5 on the clinical service items, which is very important to consider how behavioral health is in your side. Are you just seeing depression and anxiety? Or you're also invited when there's health concerns? And are you also welcoming those who are very mentally struggling by bridging services while they can go to another place?
So the goal, when you get up that HRSA 6 levels, is to really be comprehensive in your care of your patients. So the folks that are at this level 6 see all comers. So they're not usually focused on just one very niche population. They're seeing all 4 quadrants. If you know the 4 quadrants square, essentially, of folks. Now, it doesn't mean that you are solely responsible for the care of those patients with severe and persistent mental illness, for example, right? And it doesn't mean that you're solely responsible for providing, you're not doing inpatient detox for folks with substance abuse disorders, but it means you have a team that is sensitized to patients with those needs and is able to effectively work with those patients, either to do some brief intervention, to get them connected effectively, to, as Martha said, to bridge care effectively. Now, that does take time and development. So we don't expect, if you're at the first year of your development of integrated care services, we don't expect you to be at that place. But you should know what your baseline is. And that's what's helpful about doing this tool. You can say, hey, year 1, we were at maybe 10% with meeting patients' behavioral health needs, specifically in the area of, say, diabetes, right? We get a few referrals here and there that are related to diabetes self-management, right? And we were at 0% with severe and persistent mental illness. And then you can look at yourself over time and say, how are we doing in years 2, 3, 4? Are we still sort of really either ignoring that population or feeling like we're doing a haphazard job with that group, right? Or are we actually making some progress, right? Are we using our consulting psychiatrists to upskill our primary care providers to be able to bridge care for those folks who may come from the ED and say, hey, I need a refill on my meds, right? On my psych meds, right? Do you have a strategy for that? That's a good strategy. So yeah, those clinical service items, and again, this would be page 4 and 5 that we're referring to in the PDF, can be a really good for setting baseline of where you are now. And it's certainly not something you should feel bad about. Like, none of this is about evaluating yourself and feeling bad about. It's just about honestly taking a look and saying, yeah, we're not really doing very well in that area. Or, yeah, actually, we've got some good potential in this area that we can grow from.
I'm glad you're clarifying that, Neftali, that this is a tool that you can use over time just to see how much you're improving in the 5 areas that you get those results, which is the general workplace and integration, patient identification, clinical services, patient engagement, and practice workflow. So the idea is that once you evaluate your site, you will identify one of those areas that you would like to improve. And it does take time, but at least making little tiny changes, you're going to start moving that those percentage of, even if it's just one of the areas that this tool is evaluating. Do you have any recommendations, Neftali, as to how often it is useful to use this tool?
Yeah, so she's giving me a softball question there. But yeah. So typically no more than 6 months in between administration. It doesn't help you to do this on a quarterly basis, for example. And more regularly, this is something you would do on an annual basis. Yeah. And I want to highlight actually one particular question that is a very typical one that we start off with as a goal, is one of those to-dos that clinics have after they fill this out. And that's item CS1, which is on page 4. It says, we provide behavioral, non-pharmacologic care for patients with behavioral health needs. And this is a great place to start, because essentially what the definition of the item is, or do you have coverage of all open clinic hours, right? It's a really great, basic, simple, straightforward goal, and say, hey, if we're doing a PCBH model and we want to build this out, one of our first goals is making sure that every time a physician or a primary care provider is working, that they have the support of a behavioral health consultant at their side. Just like you would never not staff a primary care provider with a medical assistant, we would never not staff them with behavioral health support at the ready, right? Which is what PCBH is about. So that's a really tangible item. And if you're currently, and you say, right now we have 30% staffing coverage of all open clinic hours, then your goal then is say, hey, how can we get to 100% in the next year, right? And you create your plan, a strategic plan around, all right, what do we need to do to get there, budget-wise, hiring-wise, et cetera.
So Jen posted a question that it's kind of related to what you were describing here, Naftali. What can we tell team members who do not have integration yet, and how they can use this tool right now? I will suggest fill it out as it is, and then identify just an area, even if it's super low, 1 or 2 items that you see in the profile. Just pick it and start, working towards that. Just 1 or 2 items of a particular of those sections, I would say.
Yeah, absolutely. So Jen, what we would do in this situation, we do this is we have folks do a baseline score. And so you may think, like, why would you do a baseline score if you haven't even started, right? But it can be helpful because lots of clinics do have certain things in place, like they already have, for example, in section, the previous section, which is the patient identification section. Almost every clinic right now has some form of patient identification processes that relate to behavioral health, usually with at least the PHQ-9 and depression, right? So they're doing something in that area, right? And they can say, oh yeah, so this process is ongoing. And the importance of that is that you can learn about that process, like what's going right about that process, because every process you work on helps you build to the other processes that you're gonna need when you build out your staffing and your interventions related to behavioral health integration. So even if you don't have anything in place, it's helpful to learn. Plus, the other way we use this tool is actually as an intervention, right? So this is the sneaky part of this. It's an intervention to get your whole team on the same page related to what integrated care is. Because remember, we started last time by talking about how everybody thinks they know what integrated care is, and nobody knows what integrated care is at the same time. And so when you have a conversation around this, and in fact, practically speaking, when we're working with folks, this is what we do. We have them fill it out, we aggregate the data, and then we actually have a conversation about the results. That serves as an intervention for the team to realize, oh, so this is what it would mean to integrate care. It's not just hiring a mental health professional to sit in the corner and wait for referrals, right? So it means these folks have to be integrated into our quality processes, into our they have to be integrated into our standard daily workflows. They need schedules. They need to be included in our organizational hierarchy. We need to connect with billing around this, et cetera, et cetera. It gets people from different areas of the clinic thinking about behavioral health. It's a very different way than starting the project, where most people start these projects assigning one person to do it and then saying, all right, here's your project, go do it. This tool lets you know, oh, wait a second, it takes all of us if we're really going to do this well.
And I've added some things to the chat if people want to take a look at the chat. I've added a question about if you'd like to share this information with WCHQ so that we can add that to your goal. The one item you pick, and also just to remind everybody that we could pull data on the one item for you also to help with that goal.
Absolutely. Talking about data, actually one of the items it's related to data. And I think one of the things that we find out when we're doing technical assistance services to sites is that some of them, they have been working even with a few items of integration, but they have never collected data. And it's so important because that can give you so much information as to even how many BHCs you put on a site, or how many patients you're seeing in a particular clinic, right? Or which patients you are losing, they're not coming back. Which ones we need actually to retain or to keep a close look at. If, again, you're identifying yourself with a COCM model. So data is very, very important, but also to use it smart, because a lot of the times you also will collect data that is not necessarily, and you're spending a lot of time on that data that is not giving you a lot of information. So you want to identify data that would allow you to tell a story that maybe you can use to seek more funds, or to change your program, or to improve things on the clinic. So it's important to collect data, but also use it smartly in a way that it will be important for the story that you want to tell in your own clinic in order to use it for a particular purpose. So a way that you can do that is, first, what are the things that maybe you want to change in your clinic or improve? And then identify what type of data you need in order to answer that question. That can be a strategy. But like I said, even just starting to collecting data, it's important.
Can I stop us for just a second and ask if anybody has any questions or feedback or thoughts about what you guys have talked about so far? Any of you out there? John Marshall just unmuted.
Yeah, I just, trying to formulate the question. So, when I think about how this applies, I'm always, in some ways we've been doing this for a long time, and in other aspects of our practice, we don't do it at all. So when it comes, to thinking about, is there a standard protocol for behavioral health? Well, yeah, I mean, our primary care physicians know what the procedure is to refer through our assessment service and get somebody kind of triaged and or hopefully connected, all the way to having a pilot project where we do fully integrated treatment using kind of the Washington model. But it's kind of everything in between. So when I mean, it's kind of mind-boggling to contemplate the questions or even the survey when it's all over the map like that. I think we've got tentacles that are really exploring this, and then some places where the clinicians are not even mindfully aware of what it would take to do an integration with another healthcare provider and look at some of the the behavioral aspects of the medical conditions that people come in for. It's so I feel like we're all over the map. So even formulating a question about it becomes difficult.
And I think it's very common. It's very common that sites are all over the map, right?
Yeah, and I think, thanks for raising that, because as Martha said, it is very common. And I think what you just said is the awareness that we try to raise at sites, that your efforts are very diffuse, right? So we know what happens with diffuse efforts. There's a lot of wasted energy, right? There's a lot of organizational energy going in directions that aren't necessarily strategically aligned. That's why we started last session with a discussion on the models of care. Now, this tool is model agnostic. In other words, it's not presenting integration from the perspective of either PCBH or COCM. It's saying this cuts across all models. Now, when you get to the nitty gritty and you sit down with this tool, part of what we hope happens is that not just you, but your colleagues also have that realization. Yeah, you know what? Site X over here seems to be doing a pretty good job and actually has some really tight integration. But this site over here is just doing co-located specialty care, and they're all booked up, and providers really don't even send patients anymore because there's no way they can get in. And this clinic over here doesn't even have access, right? That's part of the conversation you want to have and say, well, as an organization, does that make sense? I mean, or do we want to adhere much more closely to a particular approach, right? Are we going to really invest resources in training our clinicians to do really good PCBH work with their behavioral health clinicians, right? Or if we have a consulting psychiatrist, right? This is another common situation where an organization has a psychiatrist, but they're operating in a specialty model. And, because of that, they're booked up for like 6 months, right? And they're inaccessible. They're not really supporting your primary care providers the way they would if they were in a COCM model, right? And so then at that point, organizationally, you hopefully direct your office to say, hey, look, if we're really going to leverage our psychiatrists and our psychiatrists' time, we really want to be then hewing towards a COCM approach with that psychiatrist and redesign how we utilize that psychiatrist. So those are the kind of questions that we hope come up in this process so that you become more focused in your efforts to integrate behavioral health at your clinics.
And Heather have a really good question here. She's asking, will you recommend this tool be used at a site level rather than an organizational level?
Yeah, so I think, yeah, you go ahead, Mark.
I was just going to say that, as you mentioned, how easy it can be that everything can be diffused and people are seeing different things. It will make more sense to start from a site clinic and then, expand it to other organization. But it's important to first start putting more energy in a more direct way.
Yeah, and I would say it just depends. It can be used for both, right? So sometimes in some organizations, the organization might be so large that doing it across that kind of a health system doesn't make a whole lot of sense. And maybe we would just target one clinic or a few clinics and have their teams respond to the assessment. But some organizations are small enough and have a more comprehensive approach that we can just do it organization-wide. So it depends.
I think the important part here is to put everybody on the same page, because like we mentioned, they can perceive things so differently, and this tool allows them to have a conversation as to how people are perceiving things or how they are seeing clinic, and then put everyone on the same page and start working towards a particular area.
Yeah, let me actually double back to an item that Martha introduced here a while ago, just to show you practically how this can be really helpful, right? And it ties in with your comment, and I think it was, is it John Marshall?
The one of the recommended on the organization?
Yep, John.
Oh.
Yeah, John. Yeah, John. I love your comment so much because it's so typical, right? So John, your comment about how your organization is kind of all over the place. So if you look at item ID4, this is page 3. So ID4, so that's the patient identification component. And so this is how the item reads, right? And I want you to imagine what it's like if you're in a team of people and you're all reviewing this item together across your organization. We regularly review retrospective clinical or other patient data from across our practice to identify patients who may need behavioral health services, right? So if your organization is all over the place with regard to the services they offer and the patient identification strategies that you have, it's going to become painfully obvious here. You're going to either sit around and say, well, oh yeah, we pulled this report over here. And over here, they're going to be like, oh, we don't actually know how many patients have need in our clinic. We don't have any way to access that data. We don't have any strategies for that, right? That really should help level set your team and say, well, actually, this is kind of important for us. We don't even know what the need is out there, right? We don't even have a sense of what the need is, and we don't have a coherent way to measure that across all our sites. So we kind of got to get our act together around that, right? That's the kind of movement that can help move your team towards that focused effort and say, what can we all agree on to figure out what the need is at our clinics? And beyond that, what we find a lot of times is a mental health professional say, oh yeah, I'm really busy. I'm booked up. I've got, and there's this feeling like they're doing a lot of work, right? And they are doing individually a lot of work. I'm not ever saying that mental health professionals like me are not busy people doing their best. But what they don't have often is data about all the missed opportunities that they have, right? So they don't know all the patients that are coming in through primary care that are being referred, put on some wait list, and then drop off that wait list 6 months later when they haven't gotten an appointment or a call or anything, right? So when you start talking about data from that standpoint, that becomes a motivating factor for the clinic to say, hey, this is not quality care here. We just have folks, dropping off wait lists here. You can feel busy. That's fine that you feel busy and booked. But that's, we're not really meeting our patient need. So then we have some hard conversations about that's why we need integrated care. That's why we need to adjust our service delivery models. That's why we need data to undergird that in order to actually say, we're meeting not just our patients' needs, but actually the needs of our primary care teams as well. So that's the kind of conversation we hope you're able to have with the key movers and shakers in your area to, again, focus that effort.
They were asking just for the link, and I'm trying to put the link here.
Get that link. While we do that, we'll move our way through here some other items before we wrap up for the day here. Time flies when you're having fun.
So I just wanted to add a comment. I got distracted by posting the link, but I wanted to add a comment as to what you were sharing, Naftali, regarding that how many people they're dropping or they're not approaching or seeing in clinic. It can be also the other part in which behavioral health providers are referring too much out as well. So the opposite, in which it's okay in some cases, they need to be referred out, but we're trying to do this in between about 10 to 15% of the amount of patients that you're referring out to specialty care. For the most part, it should be that you're able to help and provide some support to patients in your site as a behavioral health consultant.
Yeah, so that would be item WF1 on page 8 that Martha's referring to. Really key item, super key item. That's why we're going to want to talk about it, because when you design your integrated care services, if you're really adhering to, especially the PCBH model, which is very access-driven, it's an access-driven model, you don't want to see your clinicians referring folks out in high numbers. The whole idea is to do a better job with the behavioral health patients in your space, in your care team. So if you're referring more than, as Martha said, 10, 15% of your patients externally, so on that item, if you have too many referrals out, you know that you really have just developed a triage system, which of course solves no problems because the community is inundated with referrals. The specialty sector can't take anymore. The whole point of integrated care is to be able to create capacity in the medical system to provide that care in an integrated fashion. So that's really, really key. And that would be, so the to-do then would be, we need to do some training with our behavioral health clinicians so that they don't see themselves as just a triage and referral service, but they're actually providing intervention and being a good holding space within the confines of a primary care model for the patients with behavioral health need there. So really key item.
Which it had also proven through data that people prefer that, because a lot of the times, even their own needs, they cannot go and follow up every 2 weeks to an appointment with the traditional therapy or leave job, or as per, because a lot of our patients, in order for them to go to an appointment, that means they might not get paid for that hour, or they have to make a lot of logistic things in their lives to be in an appointment. So there's a lot of benefit just to be a one-stop service and have those patients be served also at the clinic, not just medical-wise, but behavioral-wise as well.
Yeah, and same thing with sort of the scope of your practice, right? So a lot of folks with MAT have gone towards, they'll ask us, hey, should we hire a certified substance abuse counselor to be part of our MAT service? And I always counsel them, no, like you don't want to segment out substance abuse as a sort of specialty service. Especially now, more and more that more and more of your providers are likely going to be prescribing Suboxone. It's not a side project. It's really an integrated part of what you do in primary care, right? And so what you need is a general behaviorist, someone who can cut across behavioral issues, substance abuse issues, run-of-the-mill mental health issues, and SPMI, who can help the entire team hold these patients effectively. So, again, same idea. You don't want to be referring loads and loads of patients out with substance abuse disorders. Not that you're going to become a certified substance abuse clinic. We don't recommend that. But that you increase the capacity internally to hold more of these patients effectively, particularly with your MAT protocols.
Another one that it's coming to my mind is, and going back to what you were saying about MAT or just, behavioral health services, is the importance of documentation, the style. We see a lot of mix match of how do providers document and how behavioral health document. And that's very important to kind of evaluate. It saves time to the behavioral health provider if we try to help them with their documentation instead of a big intake in the beginning and just kind of be like the traditional documentation. But pair the documentation template to kind of the provider, in which it's short, sweet, goes to the point, and also where are those documentation being placed? Like, is the same place as the medical providers? Is it a different place? So although those pathways are important to take into consideration to kind of allow more integration on the site. And I know that's item W13, but I cannot find the page.
Yes, I was looking for that one as well. Yeah, well, when you find it, you can do it. But yeah, so the key piece there is we often find ourselves having to retrain behavioral health personnel to write effectively for an EHR. So don't assume that the folks you hire, whether they're psychiatry, care management, or behavioral health professional, know how to write effectively in an electronic medical record, or for a medical care team. Typically, mental health documentation tends to be, let's just say, really way too wordy, lots of unnecessary detail, and very cumbersome. So you have mental health professionals who are spending way too much time writing stuff instead of just, providing the key information that the care team is going to need. And so, yes, that's one of the workflow areas to attend to. But really what we try to do is train the behavioral health professionals to mimic medical provider documentation. And so we usually train in a SOAP note format. We actually have literal trainings on this that are recorded and all that on it because we do it so often. And then we have to train folks on verbiage so that when a medical provider sees that note, they understand what's being said. They understand what their part of the job is. And it facilitates not just communication, but trust between the medical providers and the behavioral health providers as they engage patients together. So that's usually one of the key domain areas that we work on with integrated.
And that can be, yeah, go ahead, Jen, go ahead.
Yeah, I just want to make one more comment, which is that as people are working their way through this document and having team members review this document, keep in mind that you can put in a request for some one-to-one consultation time with Martha and Naftali. If you want to go over a particular section and come up with a plan, or the document and come up with a plan. So keep that in mind as you're filling out this document, that you have that available to you.
Yeah, great reminder, Jen. Thank you for that. Please use us as you know, use this time wisely with us, and I'm happy to provide a one-on-one in regards to if you give all this to your team and are wanting to us collect the data and see what are the results and kind of provide you some feedback as to what area will be helpful to start working and how to start working on that area. Let us know and we'll be happy to support you in that process. And
Yeah, so I think folks have hopefully gotten a good sense of how the tool works. So this is why we're putting it so early in our year-long time together, because this should raise a lot of questions for you at your sites. And it should raise maybe particular aspects that in future meetings you can come back and say, hey, you know, you talked about that documentation thing. Can you give us more information? So we're struggling with the documentation that our mental health providers providing HR, right? And then we can drill down into that area for you if that's a key area of need. Or hey, we're having trouble with our psychiatry folks in access, and that's really a key area for us this year. Can you help us think through how you transition someone working in more of a specialty role to someone in more of a COCM role? Right? That's why we're doing this super early on.
Going back to the documentation for those who are just starting integrated or are thinking of starting integrated care, one thing that people will look at us like, really? It's that a behavioral health note should take no more than 7 minutes or even less to be done. So that's why it's so important to kind of check how is your template, how does it look like, and if it mirrors the providers in a way that it's efficient for you as a provider to fill it out, but also for your colleagues to read it and find the information. Like, I know where the assessment is, I know what the plan, I know where if they take it or not medication. So it can be facilitate the flow, not just when you see after you see the patient, but also when you're going to see the patient again, or if somebody it's accessing your note to see what's going on with the patient.
Yeah, that's a great point. In a related point is that you will be surprised, or maybe not if you've been trying this for a while, but that typically the people who push back hardest against the changes that you will look at needing to make here are actually your mental health providers. Those are the ones that are going to be the most sticklers, and it's a funny thing, but it's pretty consistent, so even like changes in documentation patterns, folks in behavioral health have been inculcated in a certain way of thinking about documentation and comprehensiveness of that documentation, and so we have to often retrain their expectations, their understanding, so that they're not, again, spending, the way I put it to folks is, in a PCBH model, we're typically trying to see 8 to 12 patients in a typical day, right? To be highly productive is one of the pieces of PCBH. And if you're spending even 15 minutes per note, that's 15 times, let's say 10, that's 150 minutes, right? That you're spending on note writing. And that's not your greatest skill. Your greatest skill is sitting in front of patients. And so you will find that a lot of these items you may have some pushback from your behavioral health folks who say, no, that's not the way it needs to be. And then we have to retrain this. So actually, in primary care integration, that's actually the way we do things. We're reworking processes here that do look different than a specialty mental health process.
Well, we're a few minutes here to the end of the hour, but I'm really curious to hear a little bit of if people have any questions or comments, and if we don't have the time maybe to answer them, we're happy to email later to all the group. But any questions, concerns, feelings about this profile? It creates anxiety. It's like, oh, great that there's, this tool over there. Anything?
Yeah, in fact, if you could put it in the chat specifically, and trust me, you're not going to hurt our feelings. But was this helpful? Like, can you see this being helpful? Maybe rate it on a scale of 1 to 5, and 5 is like super helpful. 1 is like, not really. As you hear this, is this helpful? If you could just put a number down in the chat and maybe a brief comment if you like, that would be great. That gives us a sense of whether we're headed in the right direction with you all. As you can tell, we like to
put a number in there. It would be great. Everybody just pop a number in there, 1 to 5. I think that's terrific. And there's another question that just came in.
Yeah. Jake is asking how to become efficient with documentation and meet Joint Commission standards of documentation. And I'm trying to see, I think that's actually one topic that we have.
Yeah, we'll probably drill down into documentation. So Jake, there's standards that we think exist, and then there's actual standards. So I don't mean to be funky about that, but we've heard that a lot. Yeah, so I think a lot of times when we read those standards, we import a lot of our assumptions and expectations onto those. And so what we found is, and this is in actual practice with accredited clinics, if you do a good job of documenting a basic SOAP note, you're going to meet all those standards. You're going to be providing a rationale for care. You're going to be providing a specific plan of action. You're going to show evidence of communicating that plan amongst your team. Hopefully you have some tracking mechanisms in place for patient care and quality. So, most of the stuff is just the impact of years of being traumatized by insurance companies, honestly, that has bled into our documentation standards, so to speak. We have had no clinics, none, 0, have issues with accreditation on these issues. Now, where we have had some, I would say mild issues has been in the state of Wisconsin, right? If you are a state licensed mental health facility, right? So you're a primary care clinic, but you're also a state licensed mental health facility, they often have some pretty obtuse regulations around treatment plans, patient signing treatment plans, and things like that that can get in the way, which is why we often encourage people not to be state licensed, because it really is not very helpful in standard primary care work. There's just a few advantages that in the long run don't actually make much of a difference. So for example, a practical example, the UW Wingra Clinic that merged with the clinic that I was working at was a state licensed mental health facility. The therapist who was there before we implemented integration had a separate locked cabinet with written notes because they were a state licensed mental health facility. Soon thereafter, after we implemented integrated care, we just got rid of the license, and they lived happily ever after.
Oh my goodness. Yeah, that's a good way to put it. We're all muted?
Yep. Nope, nope, you're not muted. So we have 1 minute left, you guys. Thank you so much. I did notice that we got all 5s in the chat except for 1 4.
And if you were not able to do your homework, which is totally understandable, I hope we got you into this and you will be curious to actually do it and see, what levels of integration you get and what results you get into your site.
And remember, there's the online version and the PDF version, so either way works. All right, thank you, everyone. Thank you, Marta, for being a co-host here with this meeting. It went really, really well. And we look forward to meeting again. Again, my encouragement to you all is for the next meeting, if there are some things that you find out from this list that you want to drill down on, please come with those. We're happy to drill down in any area you wish. We have a sequence of activities that we think are pretty good sequence of what sites typically work at. But if you have something, we're going to focus on that.
Have a good rest of the week, everyone. Thank you.
Bye-bye.
Bye all.